Thank you for joining us for the third Unlocking Victorian Justice webinar in our series. And today we're talking about the harms of solitary confinement. And as we start all of our webinars and all of our meetings, I'd like to acknowledge country. I know there's people joining us from all over Australia, and we have international guests as well. I want to acknowledge elders past, present and future from all around Australia. I know we have people joining us from Larrakia country, from Gadigal country, from Wurundjeri country. So wherever we find ourselves on this beautiful land, we are on stolen land. Aboriginal sovereignty has never been ceded, and this land always was and always will be Aboriginal land. Also, I want to take the opportunity to welcome any Aboriginal and or Torres Strait Islander people joining us here today. As we all know, it's a national tragedy and an incredibly shameful part of the reality of this country that Aboriginal and Torres Strait Islander people are grossly overrepresented in the criminal legal system and in prisons and youth prisons, and so are also disproportionately impacted by the harms of solitary confinement, which is what we're speaking to today. We're very lucky to be joined by panellists from around the world, and also you'll hear today some pre-recorded segments of people with lived experience of solitary confinement, and they have very generously shared their stories and their time. And I hope that we do those stories justice here today, but also in the future as we work together towards ending solitary confinement. So I'll just briefly introduce who our panellists are today. We'll be hearing today from Professor Stuart, who is Group Leader of Justice Health at the Centre for Adolescent Health at Murdoch Children's Research Institute. We have Dr. Sharon Shalev, who is a Research Associate at the Centre for Criminology at the University of Oxford and also the Director of solitaryconfinement.org. I encourage you to have a look at that website for a whole lot of information around solitary confinement. We're joined also today by Megan Williams, who is a Wurundjeri woman, Research Lead and Assistant Director at the National Centre for Cultural Competence. And we have Kriti Sharma, who is the lead Break the Chains campaigner at Human Rights Watch. We have also provided numbers for VAR's Yarning Safe and Strong, which is a free and confidential counselling service. So if you find that any of the content that is discussed today is particularly troubling for you, I do encourage you to reach out to them on 1-800-959-563 or alternatively Lifeline on 13 11 44. Throughout the webinar, we'll be playing a few of those pre-recorded segments. And the first one is a particularly difficult account of someone's experience of solitary confinement. We've used the pseudonym Taylor to protect their identity. I think it's important to open this conversation by centering the people who have been subjected to this particularly cruel practice.
I am a woman who has struggled with drug addiction and criminalisation. I am now employed by Fitzroy Legal, working for the Women's Leadership Group, helping advocate for women who have been criminalised and the issues that affect these women. When I was 23, I spent 13 days in solitary confinement, wet cell, within the Melbourne Custodial Centre. This was approximately 2003. The reason I state this is at this stage, women could spend up to 6 weeks in the cells. I was on remand awaiting transfer to the women's prison James Lewis Frost Centre. I just had a visit with my lawyer who told me I wouldn't be applying for bail. I got extremely upset as this meant I would be spending weeks in the cells and would soon be going into heroin withdrawal. After coming out of the visit, I was crying and asked the guard if I could either be put in a cell alone or given a moment to regain my composure. She told me it was my bad luck and I better get used to it. This made me more upset and I told her to get fucked. For this, I ended up in solitary confinement. I believe this was an overreaction on the guard's behalf, to say the least. I believe it was more the guard's inability to cope in a fair and humane and understanding way. Solitary confinement is awful, humiliating, trauma-inducing. These are just a few of the things it evokes in people. I never agree with the use of solitary confinement. In saying that, it's only meant for people at risk of suicidal self-harm, as there are no hanging points and people can be closely monitored. In saying this, people who are suicidal should never be put in solitary confinement. only left with your own mind, and in certain situations, this can be the most dangerous thing. You're not supported, you're just isolated to make the guard's life easier. Solitary confinement is used as a punishment and a way of gaining power over the person. It was definitely used as a punishment in my case. If guards cannot deal with women who are struggling emotionally and possibly in drug withdrawal or under the influence, also the trauma of missing children and or family, then they shouldn't be in such a role holding such an unbelievable amount of power over people. And not that this isn't bad enough, no one oversees the guards and their use of solitary confinement. After telling the guard to get fucked, she returned me to the small cell, which was overcrowded with 2 women sleeping on the floor. I assumed it was all over. Approximately 2 minutes later, 7 guards arrived at the door. I was told to stand up. I asked why and where I was going. She said, "You're going to the wet cell." I said no and sat back down. Next thing I knew, my hair was grabbed and I was dragged to the floor and out of the cell. I was really scared and very alone and wondered why this was happening. I knew better than to fight back, as it's common to hear people being beaten. I was dragged to the wet cell. I was told by a male guard to stand up and strip off. I said no. He slapped me in the face and it really stung. I then started to strip, even though I knew I should have only been in front of a female guard and not in front of cameras. But I was too petrified to not say yes. I left my knickers on. Guards said all of it. I was humiliated and so scared. I could feel myself tremble. I wanted to fight back or hide away, but it was only me up against 7 guards, of whom male. Standing there naked, I feared being assaulted. Who would know and who would believe me? Luckily I wasn't, but the fear was really real. I feel it now talking about it. How should any human be allowed to treat another like this? I was then told to get in the cell. I asked, "What do I wear?" He pointed to a pile in the corner in the padded cell. It was all white with the strong stench of urine coming from the drain, which was the only thing that wasn't white in the whole cell. The cell door slammed behind me. I walked over to the canvas gown shaking, tears burning down my face and trying to cover my naked body. I put the gown on. It was really heavy and big. I had to hold it up around my shoulders, definitely not made for a woman's body. I was freezing and so alone, knowing nobody was coming to help me. I cannot describe how painful this was. I sat on the cold ground and rolled into the fetal position. How long would I be here? I buzzed up on the intercom, no one answered. I'm alone and no one cares. Hours passed and I heard the food crate, finally something to break up the nothingness. It didn't come to the wet cell. I banged up. I kicked and kicked at the door as no one was answering me. Finally, a guard came. His first words were to me, "Shut up, you'll get food when I say so." Not long after, they brought dry toast on paper towel. I wasn't allowed cell food or hot drinks in case I harmed myself. I said, "I'm not here for that." He just shrugged his shoulders and slammed the door. All I had was tap water and plain toast for 13 days. I was being tortured, and for what? Swearing? Nobody deserves to be treated this way. The lights dimmed a little, but it was still so bright. I had nothing to cover my face to shield from the light. I couldn't sleep. My mind was racing. I ran my hands through my hair and started pulling small handfuls of hair out of my head. It hurt, but it was strangely soothing. I continued doing this for the 13 days I was there. By the end, there were small piles of my hair all over the cell floor. When I got to the prison, my hair was cut really short because I had a lot of chance to think. Time blurred, it all became one painful moment on playback. On the second day, I asked for a shower. I was allowed. It was only a very small break. The water was calming. This was the only shower I was given. All the other times when I asked, I was either ignored or I was told no. This is a basic human right, but who could I tell and who actually cared? On day 12, the only reason I know this is because I got transferred to the prison the next day. A male guard came alone to the cell. He opened the door in a way that blocked the camera. He reached out towards my breast to touch my breast. I stepped back inside the cell crying. "I can get you out of here," he said. I cried so hard I almost couldn't breathe. I was petrified. He had such power over everything. And this is the disgrace and talks to everything wrong with solitary confinement. After the door slammed, I regretted my decision. Maybe I should have let him. Maybe I would be out of this wet cell. And this had been his sick plan. By this stage, I was sitting in a corner rocking myself. When I finally came out of the wet cell, I remained huddled up, rocking. It took months to partially recover from this experience. Nightmares, anxiety around people, loud noises scared me, and I was in a constant state of fight or flight. Upon release, I still struggled with flashbacks and intense anxiety. This scarred me for life. Ultimately, I'd like to see solitary confinement abolished. The training modules for guards just won't cut it. Solitary confinement is dehumanising and traumatic. If prison is meant to rehabilitate, which I believe it does, what part does solitary confinement play in this? It is used as a punitive punishment. It causes anger, mistrust, and fear, and it has left me traumatised.
So that was Taylor's story. I think it's really a powerful account and a very honest one. And I'm really grateful that they were courageous enough to share that with us all. And I do think that it's really important that we all, when we listen to these stories, we also recognise that there's a responsibility on all of our part to change the system so no one else goes through something similar. So on to our first panel speaker. Sharon Shalev will just generally introduce us to what does solitary confinement entail, how, when and why is it usually used and why is it harmful, and also speak to some of the New Zealand reviews that she's undertaken. Welcome, Sharon.
Thank you all. It's really good to be here today. I should say it's 8 o'clock in the morning here in London, and it's not usually a time when I'm in my sharpest, so we'll see how we go. So I've been tasked with setting the scene for our discussion today. I'm conscious that some of you won't be very familiar with the subject, so I'll focus on some fundamentals, and I hope that there'll be food for thought for those of you who already know a lot about solitary confinement. So first, what does solitary confinement actually mean? You would have thought that this is obvious, solitary confinement, but prison authorities in particular are not at all very keen on this term and prefer alternative names such as segregation, separation, or euphemisms such as secure care or intensive support, structured interventions, and so on. Others prefer more graphic names such as the hole, the box, or the pound. Happily, though, we now have a clear definition. In 2015, the United Nations adopted the Nelson Mandela Rules, defining solitary confinement for the first time in international law as the confinement of prisoners for 22 hours or more a day without meaningful human contact. So that's a basic definition, and I won't get now into what meaningful human contact means, but let's give it a bit more color. So you're locked up in an austere space, perhaps the size of an average bathroom, sometimes with a window, sometimes without, for typically 23 hours a day, every day, alone. Your 1 or so hour outside the cell is spent in a small exercise yard, often with no equipment. You may get 5, maybe 15 minutes to speak to your family on the phone and to have a shower. Sometimes you have to choose between the two. You have little or no access to prison programs, and where you do, it will typically be in cell. Boredom, as one person put it, is a major enemy. If you are a parent, and in New Zealand, for example, the majority of women in prison are mothers, solitary confinement means not always being able to contact your children by phone, and very limited opportunities for visits. When these do occur, it is often through glass and without any physical contact. As you are locked up in your cell for the majority of the day, you're almost completely dependent on prison staff for all your basic daily needs, from food to toilet paper and sanitary products to news and contact with the outside world. This level of near complete control is harmful, not only to those who are being controlled, but also to those controlling them. It is not surprising that this sort of existence leads to some very serious health issues, something that Stuart is going to talk about later. We're social animals who need others to thrive. Our daily lives consist of ongoing noise, cues, stimulation. Depriving people of those pushes many to the edge. In light of its extremity, international human rights law calls for solitary confinement to be used only as last resort and then for as short a time as possible, and no longer than 15 days. After 15 days, international law considers solitary confinement to be a form of prohibited treatment and even torture. In the time when solitary confinement is prohibited, as is its use with children, young people, pregnant and breastfeeding mothers, and people with disabilities. All these are particularly vulnerable to the harms of solitary confinement. Sadly, though, this is not the case in practice, as men, women, and children are isolated in prisons across the globe, sometimes for very long times. And across the world, solitary confinement is used for four main official reasons. I say official because, of course, in practice, as we just heard, the reasons are often very, very flimsy indeed. So firstly, with pretrial detainees to prevent collusion between suspects and to prevent witness intimidation. This is particularly prevalent in Scandinavian countries. Second, as a short but harsh prison punishment for breaking prison rules. This would normally follow a disciplinary hearing and be time limited. The third type of solitary confinement is when it is officially imposed for the prisoner's own protection. For example, if they are physically or otherwise vulnerable, at risk of self-harm, or mentally unwell. This, of course, directly contradicts the international prohibition on isolation of people who are mentally unwell, as well as, in my view, common sense. Finally, solitary confinement is used for managing people labeled as difficult or disruptive. This type of solitary confinement is typically decided on by prison managers and can last for a very long time indeed. One extreme example of the so-called managerial or administrative solitary confinement are the infamous US supermax prisons, where people can be isolated in extreme conditions for years and even decades. And worryingly, if perhaps predictably, solitary confinement is not imposed equally across the general prison population. In my own monitoring work in different jurisdictions, I routinely find a very high percentage of Indigenous people and people of color in segregated housing, particularly in the administrative segregation reserved for those viewed as high risk, whatever that means. My recent study of the use of segregation with women in New Zealand, for example, which was commissioned by the New Zealand Human Rights Commission, found that Māori women made for 78% of all segregations in a so-called management unit in one of the prisons. The learned argument in my first book on supermax prisons in the United States was pithily summarized by the university's then press officer as solitary confinement is expensive, ineffective, and it drives people mad. I continue to stand by that summary, and I hope that we go away from today's seminar resolved to work to reduce the use of solitary confinement and ultimately its abolition for vulnerable people who suffer alone in the deep and far end of prison systems across the world. Thank you.
Thank you, Sharon, for that really insightful and accessible introduction to solitary confinement, particularly for those who are joining us today who might not quite understand what exactly it is. Our next speaker is Stuart Kinner. Stuart will speak to the mental health services that are available in custody and also discuss the evidence around how solitary confinement impacts mental health of people who are incarcerated during their incarceration, but also after their release. Over to you, Stuart.
Thanks, Andrea. And I just want to start by acknowledging the traditional owners of the land that I'm on, the Bunurong people of the Kulin Nation, and pay my deepest respects to their elders past, present and emerging, as well as to any other Aboriginal and Torres Strait Islander people on this webinar. I have, I think, a relatively straightforward job here today, which is to start off by just elaborating on what I think everyone on this call probably knows, which is that people in custody, prison and youth detention, experience a much higher burden of mental health problems than the rest of the community. I won't bore you with the details again. I'm sure most people are aware of that. And perhaps what's talked about a bit less, but is, in my view, at least as important, is that people who move through those custodial settings often have very poor health, including mental health outcomes, after they're released from custody. So in other words, it's not just a question of let's just try to not do any further harm for people in custody, but also trying to do things to improve people's outcomes, including their mental health after release from custody. So my group, as well as many other researchers, have done quite a bit of work in this area. And to give you a potted summary of a whole literature in 30 seconds or less, we know that people released from prison typically experience very poor mental health outcomes. There's a high incidence of ongoing mental disorder, substance use disorder, and particularly pernicious co-occurring mental illness and substance use disorder. Despite that, the work that we've done suggests really poor engagement with mental health services, community mental health services. So people aren't accessing the care that would perhaps benefit them once they do return to the community. And we can obviously talk about some of the reasons for that. Because of that, what we do see is a high incidence of acute poor mental health outcomes. Prominent among those, some work by Rowan Borshner in our group has shown very high rates of self-harm in both adults and young people released from custody. And that's one of the common reasons. In fact, in the work we've done, about 1 in every 15 emergency department presentations in people released from prison is due to self-harm. But what we do know is that people released from custody churn through emergency departments at an extraordinarily high rate, a number of times higher than the rest of the community, and that many of those presentations, particularly among the people who churn frequently through those settings, are related to mental health problems, which haven't really been addressed effectively either in custody or after return to the community. And of course, not surprisingly, all of those poor mental health outcomes also lead to reincarceration. So it just goes to reinforce what some of the earlier speakers have said about how ineffective our system is at this stage. So what I've been asked to do primarily, though, is to talk about what impact solitary confinement has on that. And I want to start by just declaring that I'm not the world expert on this particular question, but I have had the opportunity to have a reasonably good look at the literature. And I want to just summarize a couple of the key things for you. So there was a recent meta-analysis looking at all of the research on this, which not surprisingly shows that people with mental disorders are considerably more likely. In fact, the pooled estimate is about 60% more likely to end up in solitary confinement than people who don't have a mental disorder. So in other words, among people who go to prison, those with a mental disorder are much more likely to end up in solitary confinement. So that's selecting people into this harmful setting because of their pre-existing mental health problems. There's also been a small number of studies that have looked at what impact that solitary confinement has on subsequent mental health. Now, we know that it leads to acute psychological distress, but perhaps of greater concern is there's one piece of research from Scandinavia showing that among people who go into solitary confinement, the number who develop a mental disorder is much higher than among similar-looking people who don't end up in solitary confinement. So in other words, the evidence suggests that firstly, we funnel people who are vulnerable to poor mental health into solitary confinement, and then the evidence suggests that that experience of solitary confinement compounds and in some cases precipitates poor mental health. So that's arguably a lose-lose. There's also some very good evidence that solitary confinement's associated with self-harm, and from our very courageous speaker whose recording was played before, we heard some reference to that. And this is quite sensitive stuff, but important. I think there was a very large study in the US looking at the New York City jail, where they looked at instances of self-harm in that jail. So there are around 2,100 occasions of self-harm. Now, only 7.3% of that jail population experienced solitary confinement during their time in jail, but 53% of all self-harm incidents in that jail happened among those people who experience solitary confinement. So there's a very strong concentration of self-harm, notably including really potentially fatal, very serious self-harm among people who experience solitary confinement. We also know from some work in the US by a colleague of mine, Bree Williams, that people who experience sustained solitary confinement are also much more likely to have hypertension, to develop cardiovascular problems. And that's there's probably multiple mechanisms, but a key one, of course, is the inability to maintain an appropriate level of physical activity. So very significant mental health problems, but also some significant physical health complications associated with solitary confinement. And lastly, a piece of research that was done in Denmark by a guy called Chris Welderman, showing that from a very, very large sample in Denmark, that people who experience solitary confinement were more likely to die after release from prison from unnatural causes. There was no difference for natural causes. There was a difference for unnatural causes. And that, of course, suggests again that experience of solitary confinement contributed to the risk of unnatural cause death. So that's suicide, that's drug overdose, injury, homicide, and so on. So really all of the evidence is pointing very strongly to solitary confinement, not only selecting people most likely to be harmed by that experience, but also there is mounting evidence that it contributes to further harm that's sustained not only in custody, but once those people return to the community. So we could go on about the research, but I think I've made the point. What I do want to say quickly, though, is what do we do about this? Clearly, we need to find more therapeutic and appropriate responses to people who are in distress, people who are exhibiting behaviours associated with mental health problems, with acute distress, with intoxication, withdrawal from substances, and so on, rather than putting people on solitary confinement. One of my concerns in that regard is that mental health services in prisons, and particularly in youth detention, based on the evidence that we've been able to gather, are woefully inadequate. And so in other words, if we were to say, okay, let's reduce our use of solitary confinement and instead funnel people into appropriate mental health services in custodial settings, unfortunately, the government is just not spending the money on those services at the moment. Now, it is expensive. And a key contributor to that I won't elaborate on unless people ask, is that people in prison and youth detention are uniquely excluded from federally subsidised mental health care in the form of Medicare subsidies. So as it turns out, despite this incredibly high burden of mental health problems, it falls entirely on the shoulders of the state and territory governments to fund mental health services for people in those settings, which is obviously far from ideal. The last thing I just want to touch on briefly before I hand it back to Andrea is just what has COVID done to this? Now, obviously, the kinds of isolation practices and the cohorting practices that we've seen in custodial settings in the context of COVID-19 are at least meant to be meaningfully different from those of solitary confinement, which, as Sharon's pointed out, is an inherently punitive practice. But the question is, how different are they in practice? And I think the problem here is that we just don't have the evidence. We've heard some examples of good practice with, for example, I understand Vacho bringing in iPads to support people maintaining contact with friends and family in the community. But how much of that? How much is it happening? How easy is it to access? Is that kind of connection being withheld from people for punitive reasons? And is it really enough to make a difference? Those are all questions that we should be able to answer. And as a researcher, I think they're important to answer. But right now, unfortunately, we can't.
Thank you, Stuart. That was really fascinating to hear all the studies that have been done and all the evidence that's been sort of gathered around the world on the harms of solitary confinement. And I think it's really important that we take that on board. And I suppose my hope is that this webinar can be the start of, well, not a start, it's a continuation of a conversation around solitary confinement and the importance of listening to that evidence and discontinuing this harmful practice in the future. I'll just give our panellists a moment to pause, and we'll share with you a brief pre-recorded segment from another person who has generously shared their experience as well.
Yeah, my name's John Giacomo. I'm 62. I was institutionalised, and I'm proud to say I'm rehabilitated, but I spent a lot of years in boys' homes, youth training centres and adult prisons. I was 11 when I first got arrested for house breaking and battery breaking. Yeah, I ended up in B division. That was the heaviest division of Pentridge before H division. And I was 18, 19 then, and I was scared. I went to Perth, and I forget all, and it was just the same there too. And I got 7.5 years in prison for robbing a bank, and that was just to pay drug debts and get more drugs. I was using drugs in jail, and every time I got a dirty urine, I was thrown into solitary confinement. You know, and that was awful. I started off 7 days a week, 7 days. Then the next dirty urine was 14 days, and it got up to 28 days. Like 23 hours a day in the cell. You know, when I was in youth training centre in Toronto, every time I escaped, I had to get locked up in the cell for a room, they call it, for 24 hours. It was a long 24 hours being locked up, as a punishment for escaping. And but when I was in this, like 23 hours a day in a cell, 1 hour a day out for exercise, and I wasn't allowed to talk to anyone, just one prison officer there. And then when I go back in the mainstream after that punishment, like it took me time to adjust just back to the normal people. I felt like a half a zombie. Like I just hadn't spoken to anyone for 28 days. And I was counting the bricks, just for something to do. Counting the bricks, counting the floorboards, the nails in the floorboards, all stuff like that. Just to keep myself sane. It was just can't sleep all the time. Yeah, and I was always trying to scam medication, like I'll tell lies to get out, so just so I could get out of the cell for half an hour to go and see a doctor or something. But they were, I just seen no one. Yeah, it was. I felt like a zombie. Now I've been living all these dreams in my head, you know, and then when I got back, they let me out of solitary and back into the mainstream, I just wanted to go back in there again. It was weird. I got out of 28 days in solitary, and within a week, I was paroled back into the community. I just done 2 weeks off 4 years in prison. And they threw me on. They said, "You're paroled to a drug and alcohol rehab." They said, "On your parole today, you can go." And I went, "Well," well, packed my bag. I had a box in my arm, and they got a train ticket for me, put me on the train. I hopped off at the main station. It was peak hour. There's people running everywhere. I froze. Like, wow. I'm 62 now. I've been out of prison a long time. I am permanently scarred of it. I'm still healing. From it. It doesn't solve the problem. It just gets the person away from them. Um, they see it as punishment. It's not punishment. It has long-term effects, emotionally, mentally. I understand that there's rules and regulations in prison, but the long-term effects on it forever. I see a trauma psychologist. There's another way to do things. There's other punishments. I understand, like everyone's no angels, and no one does what needs to be done within themselves and within the rules of life and society, but within being locked up, it's another world in there.
And I just want to thank John. I'm not sure if he's on the webinar today, but really grateful as well to John for sharing his story. And what really resonated with me was he's now in his 60s, and his experiences from decades ago continue to impact on him. So I think that's something that's very clearly something we should be keeping at the front and centre when making decisions around whether to continue this practice in Victoria and across Australia. Our next speaker is Megan Williams. Megan will speak to the Royal Commission into Aboriginal Deaths in Custody and what that Royal Commission said about the use of solitary confinement. And she'll also be able to speak to the impacts of systemic racism and also the recent experiences of individuals and families. Thank you for joining us, Megan.
Mandangu, thank you. And I acknowledge as Wiradjuri, I'm on the land of the Gadigal in Warrung, Sydney, and I pay my respects to their ancestors and spirits of this land and elders of the past and present. I acknowledge all Indigenous people on the line today, and I say, please stay strong and deadly. This is horrendous, and thanks to our allies and accomplices. I'm here today wearing multiple hats. As a family member of people in prison and friend, peer support, volunteer visitor to sometimes, a professor of public health, a prison research partner, prison research ethics committee chairperson and a staff trainer, expert witness, journo, and also a parliamentarian phone ringer. And the material we've heard from Taylor and John, it's just gutting. It's essential to have their experience brought into all actions for change. There's so much to be said from their points of view and also impacts of family. And it's massive for me today to also try to talk about the Royal Commission and systemic racism, but, you know, they're all so linked. And so sort of on the family side of things, one time I was booked in for a visit to see my cousin Sandy, but he'd been moved. And I rang to find out where, and then I booked in. And when I went, he wasn't available. I was told to wait a few hours and we can get you in. Then I got taken to an area that I didn't even know existed in that prison, and it was so run down with the paint peeling off and all these little fences inside and dirty air you could see in the filtered light. When Sandy came around the corner, he was handcuffed in one of those and in a convoluted sort of suit that was zip tied up, and he was very thin and pale, but he had a big smile. We had a kind of hug and he just cracked into tears and said he was totally broken, that his brain had broken. He said his mind had gone places he never knew it could go beyond the darkness. And he questioned his existence, not in a suicidal way, but a real why had he even been born human to end up treated this way. But he had also attempted suicide, and I could see the remaining sort of brownish red marks on his neck. And we cried through trying to piece together the last 70 days. And I really regret that I didn't take notes, but I kept letters that we wrote around that time. And there's just such minimal information. And also there was no written information to the family, no contact person or liaison. There was no contact with his health professionals, even though he was on 3 types of medication, and I believe the care was extremely poor. He had major anxiety attacks and hallucinations, and I, for one, felt overwhelmed about the amount of things that needed doing and swamped with terror at him dying, and also the disgusting thought that actually he might die. And all I thought was, at all costs, don't give up and let some other people know what was going on. But luckily, the relief came because of a prison transfer to deal with a legal matter. So it wasn't a human rights-based or healthcare end to that situation. The New South Wales Legislative Council did inquire into that prison and the serious concerns it had about breaches of human rights at that time. And the details shocking. And I, for one, feel angry and disgusted and sweaty and stressed about it. And how could this not affect families, but also people going through it? And I do wonder, how's his mind ever going to get back to normal? But in some ways, it's remarkable that he is a grounded, supportive person, but just currently living in a ute, lasting a few weeks in jobs, going missing. And all I can think is this is beyond trauma, and this has been incurred during and because of incarceration. So when we turn to the Royal Commission, it's 30 years since the handing down of the recommendations this year. There's 5 volumes, but only 2 mentions of solitary in volume 3 and 1 in volume 5. It's minimal. If you look at safety, there's only results in favour of workmen. And if you look at alone, we're told that all hangings occurred that they investigated when someone was alone, except for 1. So the Royal Commission was just so focused on that high rate of incarceration, but it did make 200 directives about improving health of Aboriginal and Torres Strait Islander people. And so that's what we've got to use as leverage for solitary confinement, as well as considerations of the national preventive mechanisms for the optional protocol of the Convention against torture and other cruel, inhumane or degrading treatment and punishment, the OPCAT. So please tune in about that. I just want to mention here that a Commonwealth-funded Deloitte report indicates that most of the 331 recommendations of the Royal Commission have been acted on. Not achieved as such, but acted on. And so a couple of the things that the Royal Commission says about solitary confinement, that it's a disciplinary measure. And the Commission had the Incarcerated People's Cultural Heritage Aboriginal Corporation do some research for the Royal Commission, and one in Queensland fella has been described as saying that the equivalent of total sensory deprivation is like one thing for a white person, but Murris also have to, like culture says that you have to acknowledge other Murris and strangers, and there are social repercussions if you don't communicate. And that public displays of emotion are normal, and being forced to live internally is not normal. If forced to internalise, our thoughts become ugly and we see no future. So the recommendation is about segregation or isolated detention being undesirable, and only in the highest degree of concern should it be used. And that there should be minimum standards, including fresh air, lighting, daily exercise. But we know that the standard minimum rules for the treatment of prisoners of the United Nations don't give any rise to binding obligations in Australia. There have been long-term parallels between these minimum rules and the guidelines for corrections in Australia, but they're again not legally enforceable necessarily. There's 3 Nelson Mandela rules about solitary confinement. One's a definition, one's about policies and procedures, and then one says that it should only be used in exceptional circumstances as last resort. So going back to the Royal Commission, we know that Aboriginal Torres Strait Islander people are disproportionately more likely to be in prison and have multiple health conditions and disabilities in prison. So in terms of racism, it's important to mention that we experience individual, interpersonal, institutional and systemic racism, and that these are compounding. And one simple handle I put on systemic racism is that Aboriginal and Torres Strait Islander people don't have equitable access to healthcare in prison as in the community, to which they have the right. Now, recommendation 188 of the Royal Commission says governments are to negotiate with Aboriginal organisations and communities to determine guidelines and the processes that should be followed to ensure that the self-determination principle is applied. And the UN Declaration also says that we have this right to self-determination, but the UN's been criticised on its lack of progress on that. Yet, on the other hand, the Deloitte review says this recommendation 188 is fully implemented. Now, I'm not sure what your experience of this is, and it's true that countless government documents and frameworks say that they're going to put Aboriginal culture at the centre. But I just came from a state government high-level advisory group, and I didn't witness self-determination in the planning going forward. So these recommendations are incredible about the work of Aboriginal health services in determining the delivery of medical services in police custody, in prison and hospitals, reviewing standards, including on cultural matters, training staff, developing protocols for the transfer of information, integrating Aboriginal healthcare with mental health and psychiatry in prisons, and operating early intervention programs. So there's incredible leverage in the Royal Commission to use for addressing the issue of solitary confinement, and as well as supporting families. The Royal Commission extends to families. It extends to advising on community-based options, including drug and alcohol rehab, counselling, mental health care, as well as the national leadership that Aboriginal and Torres Strait Islander people were asserted to have the right to in the UN Declaration, and also that works. So I frequently cite the economic study by Alfred for Nacho, citing the effectiveness and efficiency of Aboriginal and Torres Strait Islander community-controlled health services in achieving health outcomes. And these exceed what mainstream health services and government agencies are able to do. They provide much cheaper options and alternatives in the community, and they can provide services in prison healthcare. So let's at least trial it. My question is, why are these Aboriginal Torres Strait Islander community-controlled health services not invested in to meet need in the community, let alone in prison? And why are they even not used as a model of healthcare in Australia anyway, given that they're holistic, intergenerational, and locally focused? But as Stuart touched on, Medicare is a big issue. Aboriginal Torres Strait Islander community-controlled health organisations rely on fee-for-service income via payments from Medicare. So it means that these ACCHOs are essentially locked out of prisons, and advocacy has occurred to change this countless times, but it is a human-made tension between Commonwealth and state funding. So I call this systemic racism and the perpetuation of violence by the states that we've not had these realised. As you can tell, I could talk for hours more. Thanks very much for the chance for us to have these voices.
Thank you so much, Megan. And thank you also for sharing your personal story as well. I feel like in some ways I'm repeating myself throughout this webinar, but all of us here who are listening today, I really do think there's a responsibility for us to respond. I know that it's really hard for people to keep telling their stories of trauma, and I definitely felt frustrated listening to Megan talk about the Royal Commission into Aboriginal Deaths in Custody and recommendations that haven't been implemented. And I suppose more broadly, the lack of progress in Australia in relation to Aboriginal self-determination. And I think if we have a look at the chat while you were speaking, Megan, people want to know how to follow you and the other panellists, even if you're not on Twitter. So definitely what you're talking to is resonating with our audience today. So we now come to our final panellist, Kriti Sharma, who is going to talk about a really important report that she led, that she authored, looking at people with disabilities dying in Western Australian prisons. It's called He's Never Coming Back. So, of course, a reminder to people to contact VARS or Lifeline if they're finding the discussion today challenging. So over to you, Kriti.
Thanks, Andrea. I'd like to actually start by thanking the Victorian Aboriginal Legal Service for hosting a webinar on this important topic. It's an honor to be part of such a distinguished panel, and particularly one that includes the brave and chilling testimonies of survivors of solitary confinement. Today, I want to speak about the experiences specifically of people with disabilities, those with mental health conditions and cognitive disabilities in Australian prisons. They constitute about 50% of the Australian adult prison population. Many years ago, when I started investigating Australian prisons, my very first visit was to Casuarina, a maximum security prison for men in Perth. When I asked the staff about their use of solitary confinement, a senior prison officer proudly told me, "We don't practice solitary confinement. It's inhumane what they do in American prisons. We don't have that here." Later, I discovered that not only was the use of solitary common, but that Casuarina, this particular prison, used prolonged solitary for months on end in its special handling unit. As Sharon mentioned, while international standards state that the use of solitary confinement of any duration on persons with mental disabilities is considered cruel, inhuman, or degrading treatment, The crux of the problem is that solitary confinement remains legal and widespread across Australia. When we visited 14 adult prisons across Western Australia and Queensland, we found that solitary confinement units were full. In New South Wales, the overcrowding was so severe that specialized solitary units were chronically full. And so prisons actually started confining people even in their own cells. So why is solitary used in Australian prisons? It's primarily used for 4 different reasons: to punish, manage, protect, or ostensibly treat prisoners. And prisoners with mental health conditions or cognitive disabilities are disproportionately represented in all types of solitary confinement regimes. In a prison environment that is punitive and fails to accommodate a person's disability, prisoners with disabilities often struggle to cope, and the resulting behavior is misunderstood by staff. Instead of providing psychosocial support and accommodations for the disability, prison staff can reprimand or punish the prisoner for behavior that is perceived, and I quote, as disruptive, disobedient, or acting up. A recent 2021 independent investigation by the Inspector of Custodial Services in Western Australia found that almost 1/3 of all use of force incidents in WA prisons involved prisoners with cognitive disabilities because officers had limited training. Instead of using de-escalation techniques, staff almost immediately used and resorted to high-level force, including the use of chemical agent spray. As a psychiatrist who worked for multiple years in Australian prisons told me, custodial staff have little to no training in dealing with people with disabilities. They are treated in a punitive manner for help-seeking behavior. For example, a prisoner with an intellectual disability will bang on the door because he is distressed or in pain and is actually seeking help. But it will be seen as bad behavior and they will be punished and put in solitary. Even a cry for help can result in punishment and the person being sent down the back, as solitary is colloquially referred to. So what is solitary confinement? As my colleagues have vividly described, as Sharon said, you are locked in a cell that is no bigger than a toilet or a car parking lot. And not only does it have an impact on your mental health, but it's a deeply humiliating and traumatic experience. Because even before you are put in the cell, you will be subjected to a full body strip search. When you're in the solitary cell, you do not have contact with the outside world. To the extent you don't even see people's faces. Meals are slipped through a slot in solid steel doors. People are forced to eat alone within arm's reach of a toilet. And the risk of self-harm is high. The person is then made to wear a tear-proof gown, which is extremely humiliating. In Australia, people in solitary may even be denied family visits, telephone calls, and access to educational, recreational, and even reading materials. When the risk of self-harm becomes extremely high, you can even be moved to a padded cell, which is windowless, perpetually lit, and under 24/7 CCTV surveillance. We documented cases of women with mental health conditions being kept in these padded cells for several days, and in one case for over a month. As Megan talked about, the 1991 Royal Commission report, which found that solitary confinement causes extreme anxiety for Aboriginal or Torres Strait Islander prisoners. It has an even more detrimental impact on their well-being because they are already separated from family, kin, and community. And the services that they have access to are not always culturally appropriate. Human Rights Watch found that prisoners can spend months and at times years in prolonged solitary confinement in maximum security units. One man with a mental health condition spent 19 years in solitary confinement in a Queensland prison. He became so institutionalized that he was even afraid to come out of his cell. And so what happens is that solitary confinement can push you over the edge. As Stuart mentioned, solitary confinement is not only damaging, but can at times be deadly for people with mental health conditions, particularly Aboriginal people. People with disabilities will often resort to self-harm because proper support is lacking. Prisons are struggling to meet the need and the demand for services, and the quality of care falls short of community standards. While a death in custody will trigger a colonial inquest, Australian prisons do not publicly report on the near deaths or the incidents of self-harm that lead to serious injury. There is currently no solid national or state level data on the rate of solitary confinement and self-harm. Human Rights Watch examined over 102 cases of death in custody in Western Australia, and what we found is 60% of adults who died in prison had a disability, and the cause was often the lack of support. Even in cases where the person's disability or mental health history was well known and documented by prison authorities, staff failed to provide adequate and timely services that could have prevented the prisoner from taking their own life. So concretely, what does the lack of mental health services look like? Prisons don't adequately identify and assess disability upon entering to prison. The system relies heavily on self-identification. And this means that if the disability is not identified when the person enters, they don't get the support they need. According to the Inspector of Custodial Services in New South Wales, a 2015 report that they did found that the average wait time to see a primary health nurse in non-emergency cases was 28 days. For a doctor, it was over a month. And it was 42 days before someone who needed to see a psychiatrist could even see one. Due to the limited resources and mental health service in prison, the quality of service is often reduced to a distribution of medication through a slot in the door, monitoring prisoners for self-harm, and only acute crisis counseling. The quality of counseling varies across prisons, but is often limited to a perfunctory, "How are you doing today?" shouted through closed cell doors, allowing for the person's response to be heard across the unit, including by prison guards. A male prisoner with a mental health condition told me, "The staff terrorize people in the detention unit." One officer told him, "Heel, dog, heel," they said. They opened up the grate in the cell door and laughed at me. I swallowed batteries in front of them. One officer spat in my face. He said, "I will punch your teeth over the cell." 7 other officers were there. They said I was being disruptive. I ended up cutting my wrists open, but they did nothing. They just sat on the bed. Later, they took me to the hospital. Human Rights Watch research has found that the corrective services approach has largely been reduced to reducing the access to tools that are used to self-harm and keeping prisoners under strict observation to keep them alive. But little has been done to address the conditions of confinement, to adequately respond and provide support of mental health services. A prisoner with a psychosocial disability, a mental health condition, said to me, "There is no money for meaningful individualized counseling. There's triage, and if it's not suicidal, then it's not a priority." Take me. It took 8 months for me to see a counselor at Hekia prison. The counseling was just a 40-minute session once, and basically it was a suicide assessment. Another prisoner told me, "I was in a punishment unit for 45 days straight. It was horrible. I was fed through a hatch and didn't see sunlight except for 3 to 6 hours in that time. It felt like there was no light at the end of the tunnel." The lack of services is compounded because mental health services are not culturally appropriate. Despite, in states such as Western Australia, despite having the highest rate of Aboriginal incarceration in the country, there's not enough staff that is Aboriginal on health teams, but also across correctional services teams. Across the state's prison, only 4% of all custodial and health staff are Aboriginal or Torres Strait Islander. For example, although Aboriginal men constitute a third of Casuarina prison population, there are no Aboriginal health workers on staff. And according to the Department of Corrective Services themselves, in the vast majority of the state's prisons, there is not a single Aboriginal or Torres Strait Islander staff healthcare worker. As a result, even when there is well-meaning staff, the cultural barrier means that Aboriginal and Torres Strait Islander prisoners with disabilities often do not feel comfortable seeking services. This has been aggravated by the COVID-19 pandemic. Even before the pandemic, in September 2019, Victoria's Ombudsman's Office put out a report stating that 13,000 lockdowns were used in youth detention in a single year, purely in the interest of security, and 40% of those were attributed to staff shortage. This has become worse during the pandemic. With the pandemic, prisons have relied on lockdowns to prevent or respond to COVID-19 outbreaks, putting people at even greater risk. Even in Victoria, which is one of the more progressive states on corrections, as of 13th July 2021, prison visits are once again suspended in person, which again reduces informal monitoring. So where do we go from here? Civil society groups such as NATSILS, Human Rights Law Centre, Prisoners Legal Service, First People's Disability Network, countless others, and even the Australian Human Rights Commission have raised the alarm on the use of solitary confinement for years now. Survivors like Taylor have come forward at great personal risk, relived the trauma to testify to the harms of solitary confinement. But it is high time for Australia to take action. State governments need to immediately ban the use of solitary confinement for people with disabilities. We strongly urge the Royal Commission into Violence, Abuse, Neglect and Exploitation of People with Disability to recommend that state and territory laws, policies and guidelines be amended to prohibit the use of solitary confinement for prisoners with disabilities. We need stronger independent monitoring mechanisms. Not all states have an independent inspector of custodial services. And even when one exists, the mandate is not adequately resourced. 4 years ago, the Australian government ratified the optional protocol to the Convention Against Torture, obliging it to bring all detention sites, including prisons, aged care, and disability group homes, under independent scrutiny. While the January 2022 deadline is around the corner, according to the Change the Record campaign, federal government and most state and territory governments appear to be on track to miss the deadline. And finally, prisons need to systematically screen prisoners for disabilities upon entry into prison and then provide appropriate support and accommodations. They need to ensure prisoners with disabilities have adequate access to quality mental health services, and it's critical that they work in collaboration with Aboriginal organizations and health services to ensure that mental health services are culturally appropriate.
Thank you, Kriti, and thank you particularly for ending on a list of recommendations. I think it's really, after listening to all the traumatic, heavy content from this webinar, it's a good way to end thinking about what steps we can take going forward. I just want to play the final pre-recorded segment by Jason. He has generously written a piece specifically for this webinar about the experiences of solitary confinement.
Isolated, me waiting the next stage of the game. Keeping cautious, my mind's frame stays on course to remain sane. It's hard not knowing where you stand over and over again. Trying to guess what's next as the stress builds in your chest. The only access left to vent is a view through a mesh window surrounded by steel and cement. Still, I've got to rise above all that's been bent. Never ever forgetting the future is what you set in. So I'll strive for brighter sights and happier places. Even though society's debt can be a never-ending fight despite its cases, I'll still tie my laces and walk that extra mile, implementing plans to live a happier style, creating a strategy that'll be truly worthwhile, truly grand, to face each and every hand up by my command. I demand I will prevail, succeed and hail what needs to be unveiled. If time spent segregated has blessed my third eye, to notice the signs in disguise and rise from this plight, setting sail to redeem my life, is taking isolation to find this ultimate paradigm. Now for my final assignment, to never waste another minute, like the internet own it. So for future moments, no use in inciting riots or being scared when the lights went, even if I'm back in solitary confinement.
Thank you to Jason for that really incredible, powerful, beautiful piece that talks to what it's like in solitary confinement, but also is hopeful and looks to the future as well. We've come to the end of the extended time. I seem to never quite get the timing of these things right. I've tried to answer some of the questions in the Q&A, and I can see there's quite a few of you still online, so I might if our panelists don't mind, I might quickly open up to a question that Megan has particularly identified that she'd like to answer live. The question says, do you agree that solitary confinement is causing unnecessary distress and therefore is a breach of the international OPCAT obligations that Australia now has to maintain? So, of course, this is a question that everyone is welcome to answer, but I might throw to Megan first.
Yeah, thanks, Brett, for that question. And I do, in that experience I had, and I talk from that sort of, I suppose, firsthand experience as a person being there, and it was extreme and the circumstances around it were extreme. We then hear the extensive research that Stuart has drawn on and that the other panellists have talked about as well. So it does add up to a picture of causing distress, not responding to or removing people from distress, but causing it. And I do also question why it is so hidden and why there's not more responsibility, especially from a human rights perspective, about this in this country. So, yeah, others will, and including participants I know who've got much more experience with OPCAT than me, would be able to add to that.
I quite agree. And when I do prison monitoring visits, the first place I go to is always the solitary confinement unit, because it's the most hidden, but also I really do think that it's like the canary in the coal mine. It does give you a great picture of the prison as a whole, visiting the solitary confinement unit. So, yes, thank you.
Stuart, did you want to add anything to that?
Just really briefly, just to add to the others, that if we're going to take away something unnecessary implies let's get rid of it or stop using solitary, we do need to then replace it with something therapeutic. So it's not, reducing or eliminating the use of solitary is part one. Part two is to provide appropriate, culturally appropriate, scalable supports for people in custodial settings. We need to do both. So let's not just address the problem of solitary confinement and continue to fail people in custody with respect to responding to their mental health needs.
Thank you, Stuart. And Kriti, did you have anything else you wanted to add?
Thanks, Andrea. I mean, just to add that good practice examples do exist. There are a number of models where you can use peer support. You can provide comprehensive and meaningful mental health support and services. You can provide accommodations for people with disabilities. It's possible. It really boils down to the political will. And that's where we really need to see leadership from a number of Australian states to change not just the legislation, but also to change practice on the ground, to provide better training. Currently, prison officers can be trained for half a day when it comes to disability and mental health. The training is not often ongoing. An officer can be, in prison, supervising prisons for a number of years without having any refresher course. And so that's where the resources really need to be invested in ensuring that mental health services are adequate, quality services, comprehensive, and most importantly, culturally appropriate.
Thank you. I just really want to thank everyone for their participation, whether it's in the chat or in the Q&A or just taking the time after work to join us. Thank you to all of those people who were on the panel or provided sort of their pre-recorded thoughts as well. I think I saw one of the questions really talk to who is an expert, and I absolutely agree that an expert is also someone who has lived experience of the system, and that if we want to change the system to improve it, we have to work with people who have that lived experience of the system as well, and to really respect that, and also not to ask people to retell their stories over and over again without then taking any action on our part. Again, a reminder, if anyone has found tonight's conversation difficult, I encourage you to contact VARS or Lifeline. So thank you again to everyone who's participated, and take good care.